Our shared grand rounds is HIV, why is a simple cure so hard? And Dr. Luxon asked me if I could go over standard of care in 20 minutes. So this is going to be a brief overview. I don't have any disclosures. And what we'll do in our brief time together is just go over the history of ART, the life cycle of HIV, how we approach therapy, and the care continuum. So when we look at the history of antiviral therapy, it's been around for 3.5 decades, and we've done a remarkable job in that patients have great immune function, are doing well. We tell you to think about HIV like a chronic illness. So starting in 1987 is when AZT, also known as zidovudine, was available. 96 is when we had 3-drug therapy, which is what we consider highly active antiviral therapy. In 2006 is when a triplet came out. And so this was like phenomenal, where there was one pill, it had an entire regimen in it. The first patient was cured of HIV in 2009 from a stem cell transplant. And then in 2010, we had pre-exposure prophylaxis. Over the last decade, we've had many single tablet tablets with an entire regimen in them. So 2015 brought us Gemvoya, 2017 Juluca, 2018 was a big year for Biktarvy, Delstrigo, Simtuza. And then last year, 2021, was Cabenuva, and this was transformative. So this is an injectable HIV regimen that Dr. Kumar had alluded to, where you get 6 shots a year. So we're taking patients from taking daily pills to just a shot. Pictures, I think I would say it best. So back in 2000, often you would have to take multiple pills. Sometimes it was every 8 hours on an empty stomach. So you can imagine this is really hard to do. You can see a picture of Biktarvy and the 2018 slide. So it's this teeny pill, very effective, has 3 drugs in it, and then the injectables in 2021. I like these next 2 slides because it just shows you the bazillion HIV FDA approved medicines, but it's over 2 slides, but you can see all the different ones that we can choose from. In order, I think, to really understand how ART works, if we just review the life cycle, I know everyone knows the life cycle, but it's probably been a while since you've done virology. But as you can see here, the HIV virus needs to attach to a T cell, and it attaches to a CD4 receptor. And this is where attachment inhibitors block. And a second co-receptor, the CCR5 or CXCR4 co-receptor. And this is where these CCR5 inhibitors work. And Dr. Luxon will actually go into a lot more detail regarding attachment, as that's going to be key for cure. The virus then fuses to the T cell, and this is where fusion inhibitors work. The virus is encoded and reverse transcribed. This is where the NRTI and NNRTI family work. And then, so the RNA is converted to DNA, and then the DNA is integrated into the host DNA, and this is where the integrase inhibitors work. The DNA is then transcribed into RNA and translated into proteins. And then you get a assembly embedding of a mature virus, and maturation inhibitors block the maturation. And then there are some polyproteins that still need to be cleaved, and this is where protease inhibitors block the final stage in HIV replication. So I thought maybe the nicest way to approach standard of care is to present a patient that we saw this summer and discuss, when you start care, what would be a good regimen. So this was a 29-year-old man who has sex with men, only past medical history was significant for asthma. And he's a local middle school teacher, but was working at a camp with middle school age kids over the summer, and came into the ER in August with a fever. He had 2 different rashes, inguinal adenopathy. The first rash was this macular papular rash on his trunk. And then he had a vesicular rash that was on his neck, leg, and arms. and he had very painful bowel movements associated with bleeding. So the ER astutely isolated him, swabbed the vesicular lesion, and it was orthopox virus positive. So I think the new terminology for monkeypox is mpox to decrease some of the stigma, but he was diagnosed with mpox, referred to our clinic for treatment, and we gave him a tecfidera. And then he had asked for STD screening and PrEP. So when he was no longer infectious or contagious, he was brought back to the clinic, and he had an HIV test that was positive. So first question, and for interest of time, I didn't do a poll anywhere. So maybe for the in-house audience, we can do a show of hands. But when should you offer ART? Anyone vote for immediately? All right. Anyone after resistance testing returns? Based on CD4 count, so less than 500, or based on viral load over 100,000. And so really right now, standard of care is to give ART as soon as possible. And the Department of Health and Human Services publishes guidelines every year. And most recently, they've really promoted the rapid ART initiation. And it's really for two reasons. One, ART reduces morbidity and mortality in persons living with HIV, but it's also a public health service in that it helps to prevent transmission of HIV to others. And so what we realize is that if you can start ART as soon as possible, you increase linkage to care, decrease the time to viral suppression, and improve the rates of viral suppression among persons living with HIV. And some of this data comes from two studies that I'm just going to highlight. One is a pilot study that was done in San Francisco, and they kind of do amazing HIV work in San Francisco, where these researchers were able to, on the same day someone was diagnosed with HIV, see an HIV provider, get labs, counsel the patient, and give them ART. So patients who were diagnosed with new HIV meant that you had a negative test within the last 6 months. So it was definitely a new diagnosis. And in the past, we used to think, oh, let's get that patient into clinic, make sure they're going to be adherent, they're going to take their meds. But what this study showed is that the loss to follow-up was the same in the people who started rapidly versus people that came to clinic a little bit later. And then what we also saw is that in the rapid protocol, the HIV viral suppression happened in 1.8 months versus the 4.3 months in standard of care. And then the STAT study, which is often referred to for Rapid Start, looked at dolutegravir with 3-TC, also known as Dovato. And this is a little bit different because normally we used to give 3 active HIV meds instead of 2. And saw that in folks that got the 2 drug therapy, that they did just as well as people who had 3 drug therapy. There was no treatment resistance and no serious adverse events. And then, of course, I think everyone knows U equals U, but sometimes there's a little detail that you want to know. So what we mean is if you're undetectable for at least 6 months, you can't transmit the HIV virus. And I think this is a very powerful statement for patients when they're thinking about talking to their significant others, about dating. This is a really another wonderful reason to be on ART. All right, so second question. So same patient. We decided we wanted to start on ART, and I know the front row is all the ID experts here. So don't, if you don't know the meds, don't worry about it. But I just wanted to kind of highlight some of the meds that are out there. So would you offer this patient Dovato, which the first 3 regimens all have integrase strand inhibitors, which is dolutegravir and 3-TC. What about the injectables? Offer him Cabenuva, which is a cabotegravir and rilpivirine. Biktarvy, which is bictegravir, FTC, and tenofovir. Simtuza, which is a protease inhibitor with FTC and tenofovir, or you're just not sure? Well, I'll move on. Probably most people aren't sure. And what I want to highlight here, it's a busy slide, but the Department of Health and Human Services, the International AIDS Society, the European AIDS Clinical Society, and the World Health Organization all recommend integrase strand inhibitors as first-line therapy. So you'll see we typically follow the Department of Health and Human Services recommendations. All of these regimens involve an integrase strand inhibitor with 1 to 2 NRTIs. So that patient actually was started on Biktarvy, and I don't believe, I'm not sure if he's had follow-up just yet, but that's the way we approached him. The Department of Health and Human Resources recommendations come based on some studies that I wanted to highlight. The Gemini wanted to just really show you that 2-drug therapy, valbutekivir and 3TC work. They're not inferior to 3-drug therapy. They're no treatment resistant. So if you have a patient that you see and that's only on 2 drugs, that often is a complete regimen. And then for Cabenuva, the injectables, the FLAIR and ATLAS studies looked at giving the injectables every month versus every 2 months. And what we see is that 2-month treatment, for the most part, seems pretty equivalent to 1 month. There are some caveats, but for the most part, we are treating people every 2 months. And Atlas 2M, which looked at this time frame, we did see a slightly higher failures with the every 2 months, but I think for the convenience, most patients prefer every 2 months. Okay, so I don't want to leave you with, let's start everyone on Biktarvy. So there are a couple of things to think about. Same patient, let's say he has a notable rise in serum creatinine. As providers, both primary care and subspecialists, I think if you see an elevated creatinine, weight gain, cardiac issues, you should just be aware of some key medications that are given a lot, and just have that on your radar as something that you would want to talk to your patient about. So this patient has a rise in serum creatinine. What ART are likely to do this? And I just want you to remember tenofovir-based regimens have been associated with renal insufficiency. This unfortunately does happen over the next few years. Let's say this patient gains 30 pounds, hasn't changed his diet or exercise. The integrase strand inhibitors as well as TAF have been associated with weight gain. Integrase strand inhibitors, there have been reports of people gaining 5 kilos every year that you're on it. So that is something to be aware of if your patient is all of a sudden developing a lot of weight. And then for MIs, it's important to remember abacavir, which is a NRTI, has been associated in some cohort studies with increased cardiovascular events. Okay, so just to highlight, for integrase strand inhibitors, keep in mind the weight gain. You do see increased serum creatinine, but this is because of tubular secretion, so it doesn't really impact your renal function. And then headache, I've seen reported a lot in patients. Depression and suicidality typically are in people that have pre-existing psychiatric problems. NRTIs, which is your tenofovir, your abacavir, tenofovir fumarate and tenofovir fumarate are both associated with renal insufficiency and increased risk of osteopenia, osteoporosis. TDF, which is tenofovir fumarate, a little more so than TAF, and then TAF, of course, the weight gain. Both tenofovirs do treat hepatitis B, so you have to think about flares when you first start ART because of immune reconstitution, and if you ever have to hold meds, let's say if, someone's having surgery or is MPO, something to think about. And then abacavir, remember the cardiovascular toxicity. We also check an HLA test because you can have a hypersensitivity reaction if you don't check HLA testing before. And then there's always drug interactions, but in particular, aluminum, magnesium, calcium, antacids, we need to separate them when you're giving integrase strand inhibitors. All right, so we have these great medicines. They work really well. Why do we need a cure? I think this slide says a lot, where if you look at the numbers of people living with HIV, so the WHO puts out data yearly, and this is the 2021 data. There are 38.4 million people living with HIV right now. 1.5 million people acquiring HIV in the year of 2021, and 650,000 people dying from HIV-related causes. In addition, even when you do have access to medications, our care continuum leaves a lot of need for improvement. So in the continuum, we have 87% of people diagnosed, but when we look at who is retained in care and who is suppressed, you know, it's 50 to 57% of people. So we're doing a better job diagnosing people, but really not the best job keeping people suppressed. So, you know, what has been incredibly good news is that there have been 5 remarkable cure cases, and they all have involved a bone marrow transplant using donors who have a deletion in the CCR5. So I think everyone is familiar with the Berlin patient, also, who later released his name, and it's Timothy Ray Brown. He unfortunately has passed away with relapse of his leukemia. The London patient was Adam Castillejo. And then we actually have one female patient who's been cured. She's known as the New York female, and then 2 other patients. So with that, I just wanted to highlight again this CCR5 receptor, because that is where we're targeting for some cure in patients who actually have this natural deletion. They're often exposed to HIV over and over again and never acquire HIV. All right, so in summary, I hope you feel very confident for the rapid ART initiation, the role of integrase strand inhibitors, some of the major side effects, and need for cure.
Well, good afternoon. For those of you, I hope you know me, I'm Bruce Luxon. I am a transplant hepatologist, and I'm going to talk about HIV, and I'm going to show you why I want to do that. So as we come back in person, I very much want people I've been here 13 years, and there are a bunch of faculty in the audience who I have never seen give grand rounds. And when I ask you that, why not? You say, well, I don't know anything that I could talk on. So I actually didn't know squat about this. I guess I can say that. So choose something and learn. 80% of you could learn something, I bet. The other thing is choose a really smart colleague. So I got Dr. Balba to help me out. Set a deadline that you get stuff done. Dr. Gross and her team often tells you, when I was notified, it was like 3 weeks. Oh, Luxon, you're talking in November. Great. Get some review articles that have a lot of cartoons, and I'll show you all of those. And you don't have to be smart. You just show the cartoons. Finally, remember, if it's new to you, it probably is new to your audience. And so you can be the local expert. And so I would encourage, as I look around, there's a few guys who haven't talked yet, but come give grand rounds, learn something, be part of the team. Here's my disclosures. Gayle did not mention this, but there are actually 2 types of cure. She and I focused really on the second kind. There's a functional cure. Some people have the infection, they don't take medicines, and for whatever reason, the virus is quiet, doesn't come out, doesn't cause any problems. We're talking about a sterilizing cure where we have no trace of the virus and the body's off the medications. That's really our goal in this talk. So why is this hard to cure? I mean, I was stunned. When I practiced over in the ID clinic for my hepatitis, these guys have all these drugs. Gayle showed you all of them. We know so much about the mechanisms, but what we don't know is how to get the sneaky virus out of the reservoir. So there's an immune system that is not activated. And as Gayle showed you a couple slides, and I'll give you some more pictures, the HIV virus sneaks into the host DNA, protects itself with a moat and a mountain, and then sits there. And then it comes out eventually. Some of these cells die. The virus kills them, or our immune system does. But a lot of the cells just are sitting there in what we call latency. So here's a picture, good, of what happens. We have look at the bottom, down at the bottom left. We have resting memory cells, and that little red spot in the middle of the cell, that's the virus. It's just sitting in there. It makes a few movements and proliferates a little bit, shown in the middle at the bottom. But then if you quit trying to kill the virus and you quit taking the medicines, poof, suddenly it comes out. The T cells get activated. You can see all those virus particles kicking out there. And that's why everybody, when you're taking care of HIV patients, says, did you miss any doses? Because if you do, this is what happens. So this is another cartoon of latency. So starting left to right, The second group of cells you can see have HIV in them, and they're making viruses. We start ART in the middle of the slide, and most of the cells die for a variety of reasons, but a few, shown in the kind of yellow-orange one, survives, and there's that stinking virus in the middle. The immune system doesn't know about it. Nothing happens until, again, it comes back out. So the latency is a big problem. So one of the strategies, and I'll show you some specific names about that, is to try to get the virus to come back out so we can kill it. And that's a latency antagonist, a way to get it to come out. And then these reactivated cells we can attack. So do other viruses have latency? For those of you, Dr. Ayub is here. Yeah, you bet. We have a bunch that we see in private practice, in the primary practice. EBV does, varicella does, HIV, SMV, but HIV is particularly sneaky about how it does it. So I put this, I remember I told you I was going to show you a lot of cartoons. So when in doubt, just show a cartoon and try to explain it. So how does the virus know how to hide? We know how it hides. And so I'm going to show you some pictures as we go along. The first it does, shown here by the yellow arrow, is it moves all its transcription factors out of the nucleus where they're not active and we can't attack them, and they're not making virus. So the virus sequesters its parts. And then it has different ways that it can work on its promoters. So it hides its promoters as well. Some of them read right to left and there's a block. Some read left to right and there's a block. But it's very sneaky about how it does that. We know all that part, and yet it's still very hard to attack it. So as I've, again, told you, many details are known about the regulation. As Gayle showed you, we have drugs that can attack so many different spots in the HIV life cycle, but yet we still don't know how to fix it. So how can we not be able to fix it? Well, here's 4 strategies that we have used, some with success, as Gayle said. And they, the other thing I would encourage you, think of a really sneaky, smart name. And so we're going to talk about shock and kill or block and lock, 2 strategies shown in C and D at the bottom here. Then we'll come back to gene editing, which we're not quite there yet. And then I'll finish with the stem cell transplants that Gayle mentioned that have been successful in curative. So what's this shock and kill and block and lock strategy? Great names. So on the left of the screen, you can see infected CD4 cells. Some of them die, but some of them I showed you don't. So the shock and kill is we try to get them to suddenly spit out virus. So we shock them, and I'll show you how we can do that. And then as soon as they start to make virus, we whap them with our immune system. Shock and kill. Block and lock is a different strategy. We see they're latent and they're not doing much, and we fix it so they can't ever get out. So we block them, and then we lock them in the quiescent stage. So most of the emphasis has been shock on kill, because that will be a sterilization cure. I did want to mention one of the quick things about, you'll see slides that I use the term CART or CAR-T cell therapy. Great idea. What you do is you get some T cells from the patient. You put special genes in them that mimic things. And so they're chimeric antigens. So they now are ready to go kill things that have that antigen on them. You can see that over on the right with the CAR-T cell. You grow them up by the billions, you put them back in, and this has been used in cancer and virus treatments to go, the antibodies that are on these specialized cells that you made, go kill the cell that you want, cancer, virus infected. So here's shock and kill again. So we have the virus at the bottom in the orange. And what we need to do is get it to come out. And I listed some of those at the top. The different drugs that we have all have these great little acronyms, HDAC, HMT, PKC inhibitors. The whole idea is to turn it into an activated virus, as you see in the green. And as soon as that happens, then we can go kill it, shock and kill. How do you do that? There's a variety of ways. This cartoon shows one of the barriers that the HIV virus puts up. He wraps some of his chromatin around the nucleus so the polymerases can't get to it. And so we give a drug shown here as a histone deacetylase inhibitor. The whole concept again is that you can open up the virus, get rid of its protection, and then you can attack it. And then when you turn it on, as shown at the right of the slide, you can go kill it by a variety of ways. And here's the final step, as I showed you. You have a cell that now is expressing a little bit of virus. The immune system recognizes it, and it goes and kills it. Shock and kill. Block and lock is not quite as far along. It's just the opposite in this way. You have a cell, that same orange cell down at the bottom left, but you give some drugs that fix it so it can't ever undo itself. It never comes out of its hibernation. So you lock it into deep latency, as you see on the right side. Again, you have a patient who doesn't have active viral replication because its viruses are all locked away. Not as far along in that. Now I'm going to switch gears to, I think, the most promising, but also the most controversial. And that's, why don't we just cut the blooming virus out of the cell? So there's a variety of ways to do that. CRISPR is probably the most common one. And the concept's very simple. You have a virus, again, shown in orange at the bottom left. And you have a technique where you come in with scissors. These would be molecular scissors. And you snip out parts of the virus. You can snip out the whole virus. You can snip out important parts. Here's studies that have been done trying to decide how much to snip out and how do you get the pair of scissors. So you can use CRISPR, shown at the bottom right, zinc finger nucleases, or other nucleases that, again, can cut things at specific parts. And then what you do with it depends a little bit on which part you're going to put in. You can see at the top of the slide there, that blue DNA that's going to come in is going to shut down the virus because it's removing the bad virus, if you will, and putting in an ineffective part, CRISPR. Okay. She showed you a picture of Tim Brown. He was the first person that was cured. This is a picture of him and his dog. He was an American who was in Berlin when his cancer was diagnosed. So that's why he's known as the Berlin patient. So Gayle mentioned this CCR5, and we kind of found this totally by accident in the mid-1990s. And I'll show you some interesting data about the genetics of that. But it turns out that if you're missing part of this receptor, the delta 32 parts are chopped out. The receptor's not there, it doesn't get onto the cell surface, and the HIV can't get into it. And so this has a very distinct geographic spread, this mutation. And then I'll show you how it's tied to the Black Death. So we'd figured out at some time, the mutation occurs in mostly Northern Europeans, shown here in the dark black, okay? So England has it, Russia, the Scandinavian countries has it. And Black Death did not knock out as many people that had this mutation. So it really got people in the southern part where it doesn't have this mutation. So then people said, well, isn't that interesting? Maybe I wonder if we can do that same thing for where HIV occurs. So we did. Again, back in the 90s and late 80s, this mutation, this, if you will, protective mutation, is almost absent in Africans. Fairly common in Northern Europeans, 14 to 18%. And as you go south, it gets less and less common. And then somebody smart figured out and said, let me just see if people who have that mutation don't get HIV despite being a high rate, high risk. And indeed they did. So then people figured out, aha, that has something to do with it. Gayle showed one cartoon, and I'll show another. Here comes the virin on the left. It comes down in a normal cell. You can see the CCR5 is this 7 loops that go back and forth. The virus hooks onto it. and it gets into the cell. Pretty simple. If you don't have that virus, don't have that receptor, you can see at the bottom of the slide, that same curly 7 protein is not on the cell surface. It's sitting inside. It can't get out because of it's missing those 32 parts. So guess what? Neither can the HIV virus get in. So the Berlin patient that we referenced got a healthy donor who had this mutation. They put it into the Berlin patient and as a stem cell transplant to cure his leukemia. And so, of course, the virus couldn't get in, just as we talked about. I'll skip that one. So here's the New England Journal paper that first reported that. You have to be homozygous for the delta 32 emission because you don't want any receptors. And again, he'd had HIV for 11 years, been on active retroviral, then he got myeloid leukemia, he failed chemo, he got a bone marrow transplant, it failed, and he got a second bone marrow transplant, and both of those were from the donor who was missing this particular receptor. He stopped his medicine, he did great, until he died from his leukemia, but the very first documented cure. This just shows his viral loads as he goes along. You can see he was good when he was on active ART. Then when he stopped, took a while, then he got his bone marrow transplants and he never came back. So here he is with his doctor. The patient's on the right looking at us, and this is his German oncologist who knew they were doing something special. They weren't sure. It was a little bit of a gamble, but obviously it worked out very well. So I mentioned that CRISPR was the most controversial, and I'll just finish up with that. So this is a way where you can go in and chop out certain genes. And if you chop out the bad genes, like for this virus, or you cut out the receptor, that's great. But then you have to worry about, what if I cut out genes that make blue eyes or brown hair or whatever? So some warnings about this that were just published a little bit ago. I'd ask Gayle to start because I very much wanted to have you have a background of all the medicines that we use. She did not mention one that because it's not used, and I wanted to show you why. So remember this protein, this CCR5 on the surface is necessary. If I get rid of it, then I can cure HIV, at least in the transplant world. So what about getting a drug that competes with that receptor? So it didn't take long for one to come out. Its name is down at the bottom. And I thought, well, this would be it's an entry inhibitor, as I think you called it. It blocks that receptor irreversibly. Do we use it? Nah, not much. Great theory, very quick to development, doesn't work. So my last couple of slides are on the future. Gayle convinced you, I hope, that you're supposed to treat HIV patients immediately. And there were some studies done. This one was in Mississippi at the top of the slide, called the Visconti cohort. There was a little baby born with HIV, and they got drugs. She got drugs as soon as was born, and it never came back. So it was like, really? What a great idea. Maybe if we treat really early, we could stop it. So in France, they did a study, same idea. As soon as they got diagnosed with HIV, or as soon as they got it, but it turns out not so successful. It did come back. Gayle had a picture of a second man, the London patient, who's also HIV remission, but it's because he got the same treatment as the Berlin guy, a bone marrow transplant for his leukemia. And most recently, up in New York, they had a similar way to cure HIV. This one was a haplocord transplant, same idea. We're going to put into the body blood cells that no longer have the receptor. They just got it from a slightly different source, which was a cord as opposed to a stem cell transplant, but the same idea. So we've had various successes to get that done. So as I told you, I was going to finish up with cartoons. This is all the different strategies that have been used in the last 5 years. I did a PubMed search before I came down and looked up HIV cure on PubMed for 5 years. There were 5,000 papers. You can see the cartoons are involved in all of these. We know ways to attack the virus latency. We know how to prevent it from coming into the cell, but we haven't quite figured out how to get rid of it permanently. I'm going to skip that, and I showed you that. Okay. So I'm going to bring Dr. Balba back up to summarize and answer all the hard questions that I assume you're going to have. Thank you.